Hi everyone, welcome back to Next Level Ophthalmology. Today we'll be continuing our journey in infectious uveitis. We'll be continuing with fungal and parasitic uveitis. So what are the common fungi that are implicated in uveitis? Histoplasma, Candida, Aspergillus, Fusarium and Coccidiomycosis. From next exam point of view, you require to know only about two fungi. One is presumed ocular histoplasmosis syndrome. It is rare in India. I have not seen even one case of POHS. However, because its uniqueness and its diagnostic appearance is what I think makes it to be learnt in your at your level. So it's seen in North America in the Mississippi, Ohio, Missouri region, and the uveitis is characterized by histospots, which are around 200 microns, small areas of focal areas of choroidal atrophy seen in the mid-periphery. So usually they are asymptomatic. The only problem is when these histospots appear in the macula. So these are called macular histospots, and since there is a lot of atrophy, there can be a break in the Bruch's membrane, letting the ingrowth of choroidal vessels, which is known as choroidal neovascular membrane, which can hamper the visual acuity. So it does not require any investigations. Mainly it's a clinical diagnosis. A positive histoplasmin and complement fixation tests can be used, but they are still very unreliable. Treatment is if in case there is macular involvement, you need to use systemic steroids, and if a CNVM develops, then you have to use anti-VEGF injections. So this is how it appears. Because of the peculiarity of the infection, I want you to know about this infectious uveitis. Next is candidal uveitis, which is common in India. It is usually seen in severely immunocompromised individuals, and it can present as anterior uveitis, and more commonly it can present as multiple chorioretinal lesions or endophthalmitis. So candidal endophthalmitis is usually seen in debilitated individuals who are on urinary catheters or severely immunocompromised, COVID. These are the predisposing factors for candidal endophthalmitis. So treatment is with antifungals in the form of systemic or and intravitreal injections. So this is how it appears. So this is a case of bilateral candidal endophthalmitis. The image is so blurred because there is lot of vitreous haze. So it is usually associated with lot of vitritis, and there is, you can see balls of exudates within the vitreous. Let's take a question here. A 30-year-old woman with chronic debility and an indwelling catheter for more than 6 months presents with worsening of visual diminution upon being given periocular steroids for suspected intermediate uveitis. So there are a few hints here. Somebody thought it is intermediate uveitis. So that means that patient had severe vitritis, and whatever retinitis was there could not be seen through the vitritis. And because this vitritis was not coming down, somebody has given periocular steroids. So there is worsening. So it is definitely an infection, because anything that gets worsened with steroids usually is an infection, and fungi are known for that. So there is chronic debility and indwelling catheter, which point towards again a fungal end-of-like picture. Fundus examination of both eyes shows fluffy balls of exudates in the vitreous with surrounding haze and associated large areas of retinal necrosis in both eyes. So the picture that we just discussed. So we are probably dealing with a candidal endophthalmitis. So it is an endogenous endophthalmitis, in the sense the source of infection is from within the body. So the right answer here is candidal endophthalmitis. Match the following appearance of uveitis with the respective organisms. Toxoplasma retinitis, we all know it is headlight in the fog appearance. CMV retinitis has a brush fire appearance. Candida endophthalmitis, a string of pearls of exudates is seen in the vitreous. And rubella, we have discussed this, has a salt pepper retinopathy. So these are the terms that you have to remember for exam. Need not be that you will see these patterns clinically. So this is important from your exams. Okay. So the answer here would be A is 4, B is 3, C is 1. So the right answer here is B. So these are the typical names I want you to remember for your next exam. So moving on to parasitic uveitis, we'll study about onchocerciasis. Again, not seen in India, not one case seen by me, but it is common in Africa and it's usually referred to as it's referred to as a river blindness, and it is transmitted by the bite of simian black fly. Okay, so what happens when the fly bites? The microfilaria that are present within the fly are transmitted into the skin, and there are subcutaneous nodules that form. Then these are known as onchocercomata, along with regional lymphadenopathy and intense itching. So all these show that it is the intense allergy that is causing all the manifestations. The skin of the shin becomes lichenified and has leopard skin pigmentation. So the hypothesis for choroidal sclerosis and atrophy is proposed to be autoimmune in origin. So there is some sort of autoimmune allergy that is causing these manifestations. So what happens in cornea? There is sclerosing keratitis. In the sense, there is keratitis which follows, following which there is formation of an opacity like a sclera, and in the retina there is diffuse choroidal retinal atrophy. So again, causing blindness. So these are the two causes of blindness in onchocerciasis. So river blindness is caused by infection due to onchocerca volvulus. So all of the following are the drugs useful in river blindness except ivermectin. Ivermectin is a larvicide and it's useful in fighting against the microfilaria. Albendazole is an anti-helminthic, so it is not useful in this particular condition. Suramin, again, it's active against adult worms. Doxycycline targets something known as Rickettsia wolbachii, which forms a endosymbiote for onchocerca volvulus. So this is a gram-negative organism that is responsible for procreation of the parasite. Okay, so these are the drugs that are useful, and to combat the severe allergy we use systemic steroids. So the only drug that is not helpful here is albendazole. So which of the following is a symbiont for onchocerca? It is the Rickettsia wolbachii. Okay, I want you to remember this name, especially it is important in community medicine also. Though we don't see much cases of river blindness, we need to see it as a world health perspective. Coming to toxoplasmosis, which is more commonly seen in India, which is a more common presentation of uveitis and hence retinitis. So it's caused by Toxoplasma gondii. We can call it the most successful parasite in terms of transmission and survival. So transmission is very successful because it's difficult to prevent it, and it can be congenital or acquired. So how does a person acquire toxoplasmosis? Through the mother. When the mother has the infection during her pregnancy, the fetus acquires the infection. Okay, so if the infection happens in the first trimester, then there is a loss of pregnancy. So whatever toxoplasmosis you see as a congenital toxoplasmosis, you should understand that it's acquired during the second or the third trimester. Usually it's the second trimester of pregnancy. So when a child is born with congenital toxoplasmosis, they'll have 3 C's: convulsions, calcifications and choroiditis. So how do you get acquired toxoplasmosis? It is due to de novo acquisition of the infection due to consumption of undercooked meat or reactivation of old scars where the worms remain as paradisoids. So I'm not going into the life cycle, it's not so important from your entrance point of view. So how do you diagnose this ocular toxoplasmosis? It's mainly a clinical diagnosis. IgG and IgM can be used, but it is not necessary for diagnosing toxoplasmosis. So let's discuss how it looks. All of the following infections are known to cause solitary or focal choroiditis lesions except. So remember, there are 3 T's. This is the classical teaching we have in our entrance coaching. 3 T's are known to cause focal choroiditis. Focal in the sense there is just one focus of choroiditis. So toxoplasma is one, toxocara, and tuberculosis. Okay. So onchocerciasis does not cause solitary choroiditis lesions. Diffuse unilateral subacute neuroretinitis is usually caused by all except. Again, this is a manifestation of helminths. So what happens is the helminths keep migrating in the subretinal space, causing lot of inflammation. Helminths are usually associated with lot of inflammation, and the overlying retina starts becoming atrophic. So there is gradually, progressively, the whole of the retina becomes atrophic, and there is loss of vision. So this is usually seen in association with onchocerciasis, toxocarasis, and gnathostomiasis, but it is absent in toxoplasmosis. So toxoplasmosis, the right answer here. It is usually toxoplasmosis causes focal retinitis and retinochoroiditis. All of the following are indications for treatment in ocular toxoplasmosis. So ocular toxoplasmosis can occur as a focal retinitis lesion in the retina. So when do you treat it? You treat it only in some indications. If it is away from the disc, away from the macula, it is not causing any visual problems, we can still observe it. So indications: immunocompromised states, you certainly treat. Presence of IgG toxo antibodies, this has got nothing to do with the treatment. Presence or absence of IgG will not dictate whether you decide to treat a patient with ocular toxo or not. Significant vitritis, yes. Lesion in proximity to the macula or the optic nerve head, yes. Okay. So these are the indications for treatment. So we have understood how they present when you treat. So now next question is, how do you treat it? A 45-year-old non-vegetarian woman presents with gradual progressive blurring of vision in her right eye associated with floaters. On examination, visual acuity is 6/36. On examination, visual acuity is 6/36 and there is mild anterior chamber reaction in the right eye. And the fundus shows the following image. She is tested negative for HIV. If you closely observe this image here, there is a scar. Okay, there is an old choroiditis scar, and you see a fresh retinitis lesion sitting next to it. Okay, and there is a little bit of surrounding retinal edema. So this is classically a solitary lesion which is in close proximity to an old scar. So probably we are dealing with the toxoplasmosis here. So does not require treatment as she is immunocompetent? No, this lesion is very close to the macula. So yes, this patient requires treatment. So this is not the right answer. Intravitreal triamcinolone, big no. Steroids are given in infectious causes of retinitis. It will flare up. Pyrimethamine plus sulfadiazine for 4 weeks with folinic acid and oral corticosteroids. Yes, so this is the anti-toxo treatment that we are looking forward. Oral azithromycin with corticosteroids, this is also a treatment option, but since this is the gold standard, we stick to C as the answer. So what are the treatment options we have? We have clindamycin 300 mg QID. All these will go on to 4 to 6 weeks. Okay, cotrimoxazole 800 mg with 160 mg, and azithromycin 500 mg per day. Spiramycin is usually preferred in pregnancy, and atovaquone. So the classical treatment would still be pyrimethamine with sulfadiazine. The other treatment options are clindamycin, cotrimoxazole, azithromycin, spiramycin, and atovaquone. So what are the indications for treatment? Lesions close to the macula, lesions close to the papillomacular bundle, lesions close to the optic nerve, lesions close to a major arterial arcade. Why is this? Because it can cause a venous or arterial occlusion, significant vitritis, and immunocompromised individuals. A 6-month-old child is brought with bilateral nystagmus and a delay in visual development as noticed by a general practitioner. History is suggestive of convulsions and mental retardation. On an examination of the fundus, the following image is seen. What is the most probable diagnosis? So toxoplasmosis in babies or congenital toxoplasmosis is characterized by a scar at the macula and it is usually bilateral. So the other hints that you can get here is because the visual there is convulsions and mental retardation. Okay, because the affection is at the macula, the vision development has not happened well and there is bilateral nystagmus. So the right answer here is toxoplasmosis. It is also sometimes referred to as macular coloboma. Caeryles arteriolitis is characteristic of, okay, again there is a name that you have to remember. This is the inflammation around the arteries that is seen in association with toxo. Sometimes it may also be seen in acute retinal necrosis. So classically Caeryles arteriolitis is seen in association with toxoplasmosis. Moving on to Toxocara, it is a roundworm and is known as Toxocara canis. It can present as chronic endophthalmitis, posterior pole granuloma or a peripheral granuloma. Again, because it is a parasite, there is lot of inflammatory reaction in the form of traction bands as you see in this picture. So this can lead to retinal detachment. So the treatment is mainly treating the retinal detachment along with antihelminthics like DEC and thiabendazole. Moving on to cysticercosis, it is caused by Tinea solium. It can form a cyst within the subconjunctival space or the extraocular muscles or in the vitreous or subretinal space. When you get a worm in the subretinal space, you always get diffuse unilateral subacute neuroretinitis. Okay. So diagnosis in the vitreous is confirmed by B scan that shows a cyst-like space like you see here with the central scolex. Diagnosis becomes difficult if the worm dies and the picture is like diffuse choroiditis like we discussed. Okay. So sometimes you might need to rule out neurocysticercosis by performing a MRI. Which of the following parasites is known to cause leukocoria in young children? So leukocoria in young children is typically they are caused by Toxocara cani because the development of the granuloma, it has a white look and it can cause a retinal detachment leading to a leukocoria. That can happen very early in age. So it is a common cause of leukocoria. Which of the following is not a way to treat ocular cysticercosis? Systemic albendazole alone, pars plana vitrectomy, sclerotomy with cyst excision, none of the above. So what you should understand is when you give systemic albendazole, the worm dies, and when the worm dies, the inflammatory reaction is more severe and difficult to control. So any inflammation in the eye, especially in the vitreous, is very difficult to control and you might end up with a thicical eye. So to prevent that, you perform pars plana vitrectomy along with cyst excision and then you start systemic albendazole. So giving albendazole alone is deleterious to the eye and you might lose the eye. So this is about fungal and parasitic uveitis. See you next week.